Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen from the Department of Family Medicine and Community Health at the University of Minnesota Medical School, Duluth. Tonight, the theme for our show is Tackling Weight Problems. So if you have questions about obesity, diet, exercise, weight loss programs, or weight loss surgery, now is the time to go to your phone. Locally dial 218-788-2844 or toll-free 1-877-307-8762. Please call with your questions and we will do our best to address them. Our panelists this evening all have a special interest in weight loss. I'm happy to welcome Dr. Matthew Bettendorf, a general surgeon with Essentia Health-Duluth Clinic, Dr. James Donovan, a family physician with St. Luke's Miller Creek Clinic in Duluth, or correction, in Hermantown actually, and Dr. Stephen Park, a family physician with the Essentia Health Clinic in Ely, Minnesota. Thanks for coming down tonight. Our medical students answering the phones tonight are Callie Hess of Pipestone, Minnesota, Austin Spronk from Edgerton, Minnesota, and Becky Zimmerman of Chocayo, Minnesota. And now on to tonight's program on tackling weight programs. Good evening, gentlemen. This is interesting, should be a fun program. There's several things that we can start out with and talk about, but I think first, we talked a little bit earlier about surgical bariatrics and medical bariatrics, and I think that's where I would like to start. So, Dr. Bettendorf, I know that as a surgeon you're doing the surgical bariatrics. Let's start there. Can you describe briefly about what that's about?
Well, we offer a variety of different operations to help get a substantial amount of weight off with the goal being sustained weight loss. We offer adjustable gastric bands, sleeve gastrectomy, and Roux-en-Y gastric bypass. And each of those has different pros and cons, and each patient, it really depends on what the patient needs, where we would encourage them one way or the other. The key with weight loss surgery is to look at it as not the answer, but as a tool. When diet and exercise are inadequate and they have not worked with strong attempts at that, we get to the point of considering surgery as the next step.
Thank you. Dr. Park, I have not heard the word of medical bariatrics before, and I feel a little bit bad that I haven't heard that. I think I should have. Can you tell us a little bit about what medical bariatrics is about?
For me, medical bariatrics is treating almost every patient that walks in the door that has a whole host of the problems that are basically associated with metabolic syndrome. Metabolic syndrome is a disease that's associated with obesity, it's associated with type 2 diabetes, but it's associated with a whole host of other comorbidities that so many of our obese patients really have. And so for me, medical bariatrics is taking care of all of those kinds of problems, and as a part of that, weight loss is paramount, of course, but the goal is always to try to make the patient metabolically healthier than they were before.
Dr. Donovan, it seems like obesity is a central part of this whole discussion. Would you talk to us a little bit about what is obesity and how do we define it?
Obesity, the report came out that there's been a quadrupling worldwide of obesity. And the number that most people use is called BMI, or body mass index, and it's a measure of your height and weight, and a little formula we use. And a normal weight person, like my two colleagues here, is about 18.5 to 25. You're considered overweight between 25 and 30, and then if your BMI is over 30, you're obese. As a medical bariatrician, I use a body fat analyzer, and it gives a little bit more precise measure. And typically for a good fit average male would be about 15% body weight, he'd be of body fat. He'd be overweight between 20 and 25% and obese if he's over 25%. For women, it's a little bit different. Normal weight's about 20 to 30%. The very fit woman would be about 17%. You're overweight between about 30, 33%, and obese if you're over that 33 percentile.
I understand, and any one of you can jump on this question, that the obesity rate it's not only the adults, but now we're seeing it in the young people too. Is that true in the children?
Very much so. At the last American Society of Bariatric Physicians meeting we always have the question, who has the youngest type 2 diabetic? And that's the insulin-resistant type diabetic. And 6 years old was the record this year, and I expect this next spring it's probably going to be younger, but we are definitely seeing more and more overweight and obese children.
Steve, go ahead.
Well, I was going to say one of the things that has been one of the bad things that's happened is that, you know, as we were growing up, we would assume that we would outlive our parents. We would live 5-10 years longer than our parents, and our children would live 5 or 10 years longer than we would. And in fact, that trend is reversing because of exactly this.
You brought up the word, I think we need to talk about a little bit of metabolic syndrome earlier. Do you want to define metabolic syndrome for us?
Metabolic syndrome is a condition that affects a very large percentage of our population, and there's different definitions based upon which particular group is making up that definition. But it's basically centripetal obesity, where you carry body fat around your middle. It's associated with hypertension. It's associated with insulin resistance or elevated blood sugars, and frequently with the lipid problems that are associated with cardiovascular disease.
Insulin resistance. Who wants to jump? Jim, do you want to talk about insulin resistance a little bit?
Yeah, that's the easy way to kind of define insulin resistance is that through the normal day, when you eat a meal that's it's carbohydrate, basically sugar. When you take in sugar, you do one of two things: you either use that energy, or you store it somewhere. And so, your body uses insulin to direct the blood sugar that we've digested out of our bloodstream and into the tissues, and it goes through various tissues. What happens is people that have insulin resistance is they've gotten to a point in their health and their weight where they just can't utilize the insulin that they're making. They need more and more insulin to do the same job. And they get to a point now where they just can't make enough insulin, and their body becomes insulin resistant. So they need high levels of insulin to do the same thing they could do previously. And obesity is a large factor in that for people.
Matt, I'm going to jump just a little bit back into the surgical realm. One of the questions that comes in from Duluth is what are the indications for bariatric surgery, and how overweight do you have to be?
The typical number that's used nationwide is a BMI of 40, so a body mass index of 40 is approximately 100 pounds overweight. There are a variety of different ways to calculate that, meaning you can get an app for your phone, you can look online and search for a body mass indicator calculator. There's charts in your physician's office that you can find to see where you sit. Some folks are not quite at 40, so say that your BMI is 38 or 36, but you still have some medical problems related to your weight, such as diabetes, high blood pressure that's requiring multiple medications, hyperlipidemia, or high cholesterol. Those would qualify or allow us to proceed with surgery if the BMI was less than 40 but above 35. So generally, surgery is an option if you're about 100 pounds overweight. However, you have to have demonstrated efforts to lose that weight through various diets, through working with your primary care physician, through exercise, etc., and made reasonable attempts. And when that has failed, then the next step is to consider surgery as a possible option for you.
For all three of you, really, is there one type of surgery that seems to work better than others? There's several things that you can do. Is there one that you feel is probably the best?
I personally feel that sleeve gastrectomy is the best option for long-term weight loss currently, for a variety of reasons. What a sleeve gastrectomy is we take out about 75 or 80% of the stomach. We turn the stomach from a bag into a long, narrow tube. So we call that a restrictive operation. You eat a small amount of food and you feel full right away. Because we're not changing the small intestine or doing additional things in the belly, it's a fairly simple operation, and you don't have as many complications down the road with that. However, the weight loss is very close, and the resolution of the medical problems that go along with high weight or high BMI also improves substantially.
There's another advantage to the sleeve gastrectomy too. And viewers need to understand that this disease of obesity is very complicated, and it's hormonally driven. And the sleeve gastrectomy removes one of those hormones, specifically ghrelin, removes that part of the stomach is where it comes from, where it's secreted. And it's sort of the hunger hormone that makes you want to eat and be hungry. So it's just another advantage that the sleeve has over gastric bypass.
And that's the reason we see much better results with a sleeve compared to an adjustable gastric band. The band is just restrictive. It puts a band around the top of the stomach. It limits how food goes through. Whereas the sleeve gastrectomy is restrictive, meaning you feel full fast, but also it's a metabolic operation because of that. And so there you get the advantage of early satiety, feeling full for a long time, but you avoid some of the long-term complications that you may see with other operations such as vitamin and mineral deficiencies.
There's some questions coming in on the paleo diet, Jim. Do you want to tell us what that is and talk about it a little bit? And if it's any good and does it work?
There's a lot of advantage to a paleo diet, and it's a little bit variable on who you read, but the idea is that it almost goes along with one of my old sayings, that if you can pick it, pluck it, pull it, shoot it, grab it, or hook it, or gaff it, you can eat it. And the idea is that you're eating more fresh foods, fresh vegetables, lean cuts of meat, and more of what our ancestors ate for the first 100,000 to 1,000,000 years that we've been on this planet. And it's getting away from refined foods, getting more away from the grains, although depending on who you read, that they may include whole grains in that diet, but it's a much more natural type diet.
There's a number of other diets that are similar. The Mediterranean diet has been sanctioned by the American Heart Association as being the one that's most helpful for patients with heart disease, but it's got lots in common with paleo diet. There's the Atkins diet, there's the South Beach diet, and what all of these diets have in common is the fact that they're relatively low carbohydrate in their approach to eating. And what Jim was talking about before with insulin driving fat storage, if we lower the foods that stimulate insulin, specifically carbohydrates, patients tend to do better.
One thing, if I could add to that also, that it gets a little lost or to keep in mind, is that one of insulin's jobs is to inhibit the fat cell from breaking down fat. The idea being, if you've got extra energy or sugar floating around in your bloodstream, you don't want to raid the pantry. You want to save that for the big fast that may come from the drought that's going to happen. And so when you have high insulin levels, you don't liberate fat real well. If you can keep your insulin levels down, you more freely liberate fat and have much better weight loss.
Interesting. That's why after you get so far down with the weight, having done it a few times, all of a sudden the pounds will melt off a whole lot easier. For a person with type 2 diabetes, does it help to lose weight, and how does that benefit a person? Whoever wants to jump in.
I think we need to make a little bit of a distinction here because, at least in my approach, the disease is not necessarily type 2 diabetes. The disease is more likely insulin resistance or metabolic syndrome. And if patients eat correctly, if they limit their carbohydrate, then that will make their diabetes improve, but that will also facilitate weight loss. And so the disease is not just diabetes. It's related to insulin and how we metabolize insulin. I'm not sure if I made that. Is that clear?
I think a good way to describe that is if you had a liposuction where they suck the fat out of your belly without going through the natural weight loss, you don't get the health benefits that you do through natural weight loss. And it really is, it's not weight loss, it's nutrition and metabolic changing events that happen with the weight loss that improve the diabetes. So absolutely yes, weight loss should improve your diabetes.
Where does exercise fit?
Exercise is critical for a number of different reasons. Matt will tell you the same thing, that in order to sustain weight loss, exercise is really, really important. Exercise burns calories, but one of the real advantages that exercise has is that exercise makes our muscles more insulin sensitive. So if we are more insulin sensitive, you don't make as much, you don't need as much. Everybody thinks that you go to McDonald's, eat the Big Mac, eat the fries, it's 2,000 calories, you got to burn that off, and that's kind of crazy. You can't do that. But what exercise does do is makes your muscles more insulin sensitive, so you don't need as much insulin, so it makes it easier to lose weight.
Very good. Other comments on the exercise? How much exercise, as long as we're there?
In general, it depends what your goals are. For weight loss, the saying is you need 90 minutes a day. But I really try to think with my obese patients, you know what, you're carrying around 60, 70 pounds of weight, you're doing some exercise already. But I try to shoot for at least 30 minutes a day or about 200 minutes or so a week to begin with. And I find that for weight maintenance, when people lose their weight and keep the weight off, they need about 60 minutes exercise. And that doesn't necessarily mean going to the gym and being on the treadmill for 60 minutes. It means getting about an extra 6,000 steps in a day, about 3 miles of walking for the average person, which you can do as part of non-exercise activities, taking stairs, taking one bag of groceries in at a time from the car instead of a great big handful. Just all those little extra things, that they all count as exercise. But you need about an extra 6,000 steps a day to keep the weight off.
I would agree, about a half hour a day, 5, 6, maybe even 7 days a week.
With surgery, just to switch a little bit and bring you back into this, can a person be physically ready and indicated for surgery but not mentally ready?
Absolutely. Absolutely. There are many folks who are going through difficult times in life, whether that be a divorce, they're struggling with depression, they have a condition called bipolar disorder that's not well stabilized. This is not a good time to put a major life change in effect and go through with surgery, where you're going to have some substantial changes and stressors. So in our clinic, we always do a psychological screening and evaluation and then look for any untreated or any unstable characteristics that we can assist in smoothing out or leveling out so that you're in good shape before we would consider going to surgery.
This is a bit of a gender unbalanced panel. So one of the questions, should men and women have different weight loss strategies?
I don't really think so, because again, like I come back to what I was talking about before, it's metabolic syndrome that we're really treating. It's the patient's metabolic health. And I don't think that there's a big difference in how we treat that, whether you're male or female. Everybody's different, and the approach to each patient has to be individualized, but I don't see a sex difference between them.
I agree.
I think actually one thing I would add that men and women tend to do differently is that with exercise, when trying to lose weight, women tend to do more aerobic type things and men try to do more weight resistance type things. I think they both need to do both. I think women would greatly benefit from weight resistance exercises for the very reasons he talked about, and men would benefit from doing a little more aerobic for the conditioning that they'll get from that also.
And muscle mass.
I couldn't agree with that more. Women really don't understand how important strength training is for them.
What about us old guys?
It's important for everybody. Strength training in us old guys helps prevent falls. It makes picking up that bag of groceries and bringing it in from the car easier. Helps prevent osteoporosis. Strength training is really pretty important a couple of days a week for everyone.
What's the best way to eat a balanced diet without getting too strict on restrictions? Is there a good guide for base portions on? I'm sure you guys, when you talk about diet with in your work, you must have some hints about size of portions or how you divide the plate or those type of things.
I got lots of ideas on that.
I know, it's like, do you have an hour?
Yeah. We tell patients to use small
I was trying to
plates.
decide if you're not going to say anything or if you're going to explode. I
No,
couldn't know for sure.
there's lots to talk about. Small plates, eat slow to prevent the ghrelin from kicking in, or from too much ghrelin, to allow the ghrelin suppression to occur. And I explain to patients to limit the white stuff: white bread, white flour, white rice, white noodles, white potatoes, sugar, and they can eat as many vegetables that grow above the ground they want, but watch the root vegetables.
I would agree. Small plates is really an easy place to start. There are actually, if you look at older homes, normal 12-inch plates that we have in the United States now don't fit in those cupboards because they used to be 9-inch plates. And so I think going down to a smaller plate limits how much you can put on your plate. The other thing you can do is avoid any of the servings that you have touching. If they're not touching, it forces you to downsize your portions, but you still have a nice plate of food with a variety of things to eat. So there's some simple tricks like that that can really make a difference. The other thing to think about is when you take your time and eat, when we're not rushed at lunch and take 6 minutes to pound a sandwich, you sit down, you eat, you take a little more time, it gives those it gives you some time for your stomach to signal your brain of you feel full. And so then you don't polish off the other half of the sandwich, because if you're full, push the plate away. It's okay if mom told you to clean the plate. You don't have to. If you're full, be done.
I always said that a buffet, to me, a fat man, is like an open bar to an alcoholic, and for that reason. Why is weight loss surgery such a long, drawn-out, complicated process in the United States and so easily attainable south of the border?
Good question. I think it's results-driven. In the United States here, we want the best results possible if we're going to put you through the risks of a surgery. It's not, if you go south of the border, it might be more of a financial-driven thing, whereas here, the medical community really focuses on best-case results. And so if we take our time to make this decision for a life change and really work on developing good habits that you're going to carry through for the rest of your life, the chance of you keeping your weight off is far, far better. It would be an absolute waste to go through and have something like a gastric bypass and go through the risks and the pain and the recovery and all of that and then gain it right back. That would be an absolute waste of time and effort and risk. And so the reason that it's a lengthy process up front is to make sure that you're ready, to make sure all those psychological issues are cleared and dealt with, to make sure you're into a good exercise program, and to understand exactly what's going to be happening.
Is there a fair amount of morbidity and mortality with gastric surgery? I think with the old Roux-en-Y's, I always remembered that there seemed to be a lot of difficulties afterwards.
There are complications with every operation, and we've worked hard to minimize those and make it as safe as possible. Right now, weight loss surgery is only slightly riskier than gallbladder surgery as far as a risk of death and a risk of major complications. So it's really quite safe at this point. As far as the risk of death, it depends on the operation that you're pursuing, and it also depends on the patient that we're operating on. A 65-year-old gentleman with diabetes and a history of stroke and high blood pressure and everything else is going to be more high risk than a 24-year-old who has obesity or morbid obesity and high blood pressure but nothing else. They're a healthier person, so their risks are going to be lower.
Do you do this with the scope?
Everything is done laparoscopically now.
This is a interesting question, and it can go beyond this, but with someone with a physical disability, cerebral palsy, arthritis, fibromyalgia, how can one effectively lose weight, especially during a Duluth winter?
I'd like this one. When I do my lectures on obesity, one of the things I talk about is what I call an equation for life. Your total energy expenditure for the day, how many calories you burn, about 60 to 80% of them are all based in your basal metabolic rate. About 10% goes into digesting your foods, but about 60 to 80% of the food, all it does is keep you warm. And in Duluth, that's extremely important. But the fact that so many calories are fixed, reducing your portion sizes, reducing the calorie intake is going to have a major benefit. For the average person exercising, they can burn about an extra 10% of the calories. So the exercise isn't as important in weight loss as calorie restriction is, and doing the right kind of calorie restriction is important. The other thing I try to encourage people to do is non-exercise activities, where you're taking stairs instead of the elevator and things like that. But because most of the calories we burn every day, all they do is boil the water in our body, is calorie restriction can work well for people with limited mobility.
And even with limited mobility, everybody can do something.
True. Fatty liver, fatty pancreas. Weight loss help that?
Yes.
Very good. Are there such things as power foods to spike metabolism?
There's certainly foods that slow metabolism.
Yeah. That's a good way to describe it.
Specifically, I would go to the refined carbohydrates, the sweet stuff, sugared beverages, fruit juice. Those will all slow metabolism. They make you store calories rather than allow you to burn them.
Any positive outcomes from a liquid flush diet?
If you're going to have a colonoscopy.
And that's positive.
Yeah,
That's true.
No, a lot of these flush diets, you feel better in the short run, but really what you've done is not drank your soda pop and had all your refined sugars and you feel better. But no, I try to avoid the fatty stuff like that.
Protein powders of any help?
Sometimes they're of value with patients. I struggle sometimes with patients that don't like to eat breakfast, and so they can add protein powder to a beverage of some kind, so it's advantage there if they won't eat otherwise.
Thank you, gentlemen. A shout out and a good evening to our old friend, Dr. Ben Owens. I hope you're feeling well. I want to thank our panelists, Dr. Matthew Bettendorf, Dr. James Donovan, and Dr. Stephen Park, and our medical students, Callie Hess, Austin Spronk, and Becky Zimmerman. Please join Dr. Alan Johns for a program next week on cancer when his panelists will be Dr. Basim Goali, Dr. Peter Kabekis, and Dr. Emily Onello. Thank you for watching and good night.